Hello, my name is Julia. For my final project, I examined MDMA as a potential treatment for mood disorders, as well as evidence supporting its efficacy in trauma therapy. MDMA is most commonly known as ecstasy. It is taken orally in both recreational and therapeutic contexts. It is part of the phenethylamine family, which consists of stimulants and hallucinogens, and it is fully synthetic. There are several potential precursors, but they can all be derived from saffrol, which can be derived from sassafras plants. This is a timeline of MDA's status over the past 100 years. It was synthesized originally in 1912 as a blood clotting agent. In 1985, MDMA was classified as a Schedule I drug. The hope is to gain FDA approval by the end of this year for MDMA as a treatment of PTSD. So MDMA is typically administered orally, as I mentioned before. While it is not entirely clear what the exact depot binding effects are, we know that it is enteral, thus subject to the effects of the gastrointestinal tract, and that it also undergoes first-pass metabolism, which will evidently slow absorption and limit bioavailability. The peak plasma concentration occurs in about 2 hours, and it is metabolized by the CYP2D6 enzyme, which is highly concentrated in the liver, as well as brain areas such as the cortex, hippocampus, and cerebellum. Interestingly, CYP2D6 is also involved in the metabolism of antidepressants, providing a bit of a precursor to our drug effects. The half-life is around 8 hours, meaning it would take roughly 40 for 95% clearance. Something unique about MDMA is that we see this non-linearity of metabolism. On the left, we see a diagram from a study conducted by De La Torre et al., where they observed the plasma concentration of MDMA versus HMMA, the corresponding metabolite, following the administration of doses ranging from 50 to 150 milligrams. In lower doses, we saw an increased concentration of HMMA as we would expect. However, in higher doses, MDMA was dominant. A potential explanation for this is that MDMA is inhibitory to the CYP2D6 enzyme, leading to an increased bioavailability at high doses. MDMA is an indirect agonist. It binds the serotonin, dopamine, and norepinephrine transporters, leading to an increase of these neurotransmitters in the extracellular space. If we take a look at this diagram depicting a serotonin or 5-HT neuron, we see MDMA mimicking 5-HT and entering the cell via our transport. It then prevents VMAT2 from storing what it believes is serotonin in the cell where it will accumulate. MDMA then releases serotonin back into the synaptic cleft, where we evidently see a greater concentration over time as the postsynaptic cell continues to fire. MDMA also binds to sigma-1 and sigma-2 receptors, which are speculated to be one of the sources for its efficacy in treating anxiety and depression. Alexander Shulgin was a pharmacologist and chemist who did quite a bit of experimentation with MDMA, which he records in his autobiography Pikel. For the sake of time, I'm not going to read all of these in full, but since we are addressing MDMA in the context of therapeutic potential, I wanted to point out this last quote, where Shulgin states he could talk about deep or personal subjects with special clarity. As I mentioned earlier, MDMA is seeking FDA approval this year. In DEA Phase 2 trials, participants reported improvements such as emotional regulation, cognitive insights, and coping strategies. Looking at this diagram, these are all qualities we seek to treat in the case of depression, PTSD, and anxiety. The goal with MDMA is to allow individuals a healthy alternative form of processing that they can walk away from with improved insights regarding their unique situations. MDMA is only administered during these sessions. We see that after 2 to 3 active doses over the course of 2 months, 55% of PTSD patients no longer met diagnostic criteria. The largest risk factor while on MDMA is serotonin syndrome, due to the serotonin overactivity. This can occur in both mild and life-threatening ways. For withdrawal after binge use, we're going to see symptoms that are the inverse of our drug effects, such as depressed affect, anxiety, and attention difficulties. There is not a high addiction rate for MDMA, although there is a slight increase in dopamine. There is not an extreme effect on the reward system. Over time with chronic use, serotonergic structures will downregulate or cease to function well due to hyperactivity. This contributes to the withdrawal symptoms I mentioned before. Here is a brief recap of everything that we covered today and information if you'd like to learn more. Thank you.